and welcome. We're going to be talking tonight about the very big, very important topic of Alzheimer's disease. With me is a woman whom I've heard speak about this topic, and I've learned so much from her. I've heard her a couple times, and every time I've been taking mad notes and learning new things, even though I'm often working in the field of gerontology. So I think you're in for a treat in terms of learning more about what we know and what we don't know about this disease. Deborah Richman is my guest. Debbie is the Vice President for Education and Outreach for Alzheimer's Minnesota and North Dakota. And this is a recent promotion. You were the Associate Program Director, so congratulations.
Thank you.
Well, I want to just jump in and maximize our time with you. The numbers of people that we read that have Alzheimer's seems to be, the numbers are getting bigger, of course. I read that Alzheimer's is the sixth leading cause of death.
Yep.
I don't know that many people know that. I think they know it's a horribly chronic and debilitating disease, but sixth leading cause of death. Has it been up at that high ranking level for a long, long time, Debbie?
I think it's hard to say for sure. You know, we've known about the disease for a long time. It was actually identified in the early 1900s, although we called it a lot of different things. So only in the last maybe 30 years have we really started to take notice of the fact that it's a pretty serious condition among older adults. There was an article that came out last year from the Centers for Disease Control, the CDC, suggesting that Alzheimer's disease could potentially even be the third leading cause of death. But we don't have good data yet in terms of the number of people that pass away every year from the disease to know that for sure. So it is in the top 10. And I think as the baby boom generation ages and more folks hit that 65 plus age group, we're only going to see, as you indicated, more and more. They estimate about 16 million by the year 2050 are going to be impacted by this disease.
60 million.
16.
Oh, 16.
Yep,
oh,
16.
That's not as bad.
It's not as bad.
But 16 million,
Yep.
that's a huge number. And that's going to press our healthcare system to the max, isn't it?
It's already pressing it. They suggest that this disease is the most expensive condition out there. And when you think about whether you're caring for somebody at home or whether you look at residential care as an option, when those facilities can be $5,000, $6,000, $7,000 a month and more, that can tap somebody's retirement in about a minute. And so it can be really, really expensive for families to provide care.
One of the troubling things is that we really don't have a handle yet for sure, do we, on cause?
No, we don't.
It seems kind of unbelievable to me with so many people having it and research being done, although not enough research. What are a couple of the main theories that are looked at and considered?
We know that there are certain risk factors. For example, we know that diabetes is a risk factor to develop Alzheimer's disease. We know that cardiovascular problems can be a risk factor. And when you think about it, those conditions often have a connection to the heart or circulation, right. And how the heart relates to the brain is a critical piece, I think, in Alzheimer's disease. Recent research really focusing on lifestyle, exercise, different types of exercise, using your brain, cognitive activity, eating right, all of those things suggest a much more intimate relationship, if you will, between the heart and the brain than we've really thought about before. And I think the more research that we're able to do, we can further look at those connections. There's research to suggest that education level might be a factor. On the other hand, we don't see big differences in terms of higher education versus not as high in terms of the numbers of people. It's pretty equal opportunity in that way. So we're still really searching for the what. We also don't know how to treat it beyond the symptomatic treatment. We can't delay it. We can't slow it down. And when you think about different types of cancer, prostate cancer, even breast cancer, heart disease, HIV, which if you remember back to the early 80s, if you were diagnosed with HIV or AIDS, you were dead. There was really
the death sentence.
No time. And now that's not the case. You know, the federal government invested a lot of money very early on, and they've got very effective treatments. So that diagnosis now is not an immediate, I'm going to be dead in a year. Alzheimer's disease, we don't have any of those things available. So where those other conditions are actually declining in death rates on an annual basis, between 2000 and 2010, Alzheimer's disease deaths increased by 68%. So we know that when money is pumped into the system in terms of research, and the research community suggests about $2 billion a year is what it takes, and we're not anywhere near that.
Where are we? A million?
We're about a third maybe of where we need to be. In this last congressional year on the federal level, we did see some money come into the research pool, but we need more. The state of Minnesota right now is actually pushing a bill. In fact, I'll be testifying the next 2 days at the Senate and then at the House, talking about a research bill that will put $10 million into research just in Minnesota. We have some fortunate people here in Minnesota with the Mayo Clinic and their Alzheimer's Disease Research Center at the University of Minnesota, regions, health partners, and more that I'm sure I'm not mentioning. With a lot of research being done, and we'd be one of only a few states to really look on a state level at funding research to see if we could influence the global picture of the disease.
There's a woman at the U that I read about, Karen
Ash.
Who's still here in Minnesota, correct?
She is still doing research at the U.
Okay, that's very exciting to think of 10 million coming to Minnesota, if in fact it happens. When will we know for sure?
Well, it would pass in this legislative session, so sooner rather than later, but still not soon enough if you're already dealing with the disease.
Right.
Hopefully for the future, it could potentially have some significant impact.
So when we think there's no treatment, there's no cure, there's no cause, it's got to be one of the hardest diagnoses for a doctor to give a family member and to give the patient of all time, isn't it?
Yeah, it's a difficult diagnosis because there's not a roadmap. You know, there's not a manual that you can give to a family and say, this is what's going to happen, this is how it's going to happen, and this is how long it's going to take. The disease can be anywhere from 3 to 20 years, depending on how it progresses in the individual. I've seen it more, I've seen it less.
What's kind of the average? Is it more like 10 years?
No, I've heard 5 to 8. I've heard 8 to 10, probably in that middle range a little bit. But it's very individual, and different factors can impact the length. You know, if you've got other physical problems or other health conditions, that can certainly have an impact. If you're diagnosed younger, so when we see people under the age of 65 diagnosed, oftentimes they're physically quite a bit healthier than somebody that's, say, 85, which is a more common age to see the disease. So sometimes that can indicate or mean that maybe they're going to live longer.
Although, isn't it true, too, that if you have early onset Alzheimer's, it's usually a more aggressive form? Or is that not the case?
We tend to see that, although I wouldn't say that that's a theory. There's not a lot of evidence to support that. In my experience, I have seen that, where when you see somebody that is diagnosed in their 40s or 50s, that it does seem to progress a lot faster into those later stages. But then if they're physically healthy, they can plateau a lot longer in those later stages. But again, it's very dependent on the individual, and I hesitate to say that it's that way all the time. But in my experience, I have seen that.
The statistic of being in the mid-80s and looking around and seeing your friends with Alzheimer's, I mean, it's pretty bleak, isn't it? 1 out of 3, 1 out of 2. What's your number?
The statistic right now is over the age of 65, 1 in 9, over the age of 85, 1 in 3. So age, barring any of the other risk factors, age is still, bar none, the greatest risk. So the longer you live, the greater the risk of the disease. And the irony with that is we want to live a long time.
Right. Everybody thinks they do, at least. And
so there's this thing there as you get into older adulthood that right now we can't prevent. We can't do anything to make sure that you're not going to develop the disease. So when we want to extend life, it's rather interesting that then that disease is there And the odds are really in your favor that you're going to end up with some type of dementia at some point once you get past that age.
That's an important statement you just made, though, because there are many, many types of dementia.
Yes.
Alzheimer's, the most common, I believe.
Yep.
But only one of, 39 or 42, or what are there now?
A lot. When I've talked with Dr. Ron Peterson from the Mayo Clinic, he says more than 50.
So the number's going up.
So
I
that's
think
a
it was
safe.
39 for a while, and
Well, and there's dementias that come with things that are not necessarily permanent. You know, dementias that are associated with infections, or dementias that might be associated with general anesthetic after a surgery. But you've also got dementias related to Parkinson's disease or frontotemporal dementia, dementia with Lewy body. You know, Alzheimer's disease is the big one. Somewhere between 60 and 80% of dementias are going to be Alzheimer's type. But that's not a guarantee. So you could have another type of dementia altogether. And I think that's a hard thing for the public to understand. Dementia is really that umbrella term. And if it helps to think of it more like cancer, when you get a cancer diagnosis, the question is what type? Dementia is the same way. So if you have a dementia diagnosis, what type?
Yes.
By itself, it doesn't exist. It's caused by something. So I always tell families, if the doctor says that you have dementia, what kind or what type of dementia does he think you have?
We used to say that we can't be sure it's Alzheimer's until people did an autopsy. But that's not true anymore, is it?
To get that definitive, absolute 100% diagnosis, you still have to do an autopsy.
Okay.
But we're in the upper 90th percentile of being able to diagnose pre-death. So that's pretty good.
And how is it diagnosed?
It's diagnosed through a series of things. They always do a very detailed history and physical, looking at family history, looking at other medical conditions that may also cause similar symptoms, or things that we say mimic dementia. Things could be like depression or thyroid problems, just as a couple of common examples. There's a series of cognitive tests that are typically administered either by a neurologist or a neuropsychologist. And it's not the cognitive screens that when you go to the doctor when you get a little bit older and he asks you maybe who the president is, or
count backwards from 9.
Those are screening tools, and we're talking about tests that are several hours and can be over a couple of days. They may do an MRI, which is obviously an image of the brain. They may do a PET scan, which is another type of brain imaging. They may do a CAT scan, although a CAT scan is not going to show as much as an MRI will. And after all of that information is gathered, then they evaluate that information, and that's usually when the diagnosis will happen. So it's not a quick process, and it's not uncommon that people are diagnosed incorrectly first before they get through the process. They may be diagnosed with depression. I have a friend who was diagnosed with postmenopausal depression, and then a couple of years after that was diagnosed with Alzheimer's disease. So it's not uncommon that it will look like something else, and so sometimes that process can be very long and very difficult for families when that happens.
You know, as I'm hearing this, I'm thinking, but if there's no treatment, Debbie, why go through all that testing and all the expense if there's nothing we can do about it?
Well, actually, there are things you can do in terms of the diagnosis. And at the Alzheimer's Association, we really talk a lot about living well. And when you don't know what you're dealing with, it's harder to plan. It's harder to make those decisions. And when you know, when you can name the problem, you know, I think I've heard from a lot of people that they just want to know what's wrong when they're having difficulty with memory or difficulty functioning. If it's something they can fix, they want to fix it. If it's something they can't fix, at least then they know what to do next and how to deal with it. So we want people to take that opportunity to plan. And there's a lot of planning. There's a lot of legal and financial planning that needs to be done. And frankly, that should be done with or without an Alzheimer's diagnosis. Healthcare directives, conversations with your family about what you want, what you don't want. But then really maximizing the time that you have. Maybe you travel. We have a client right now, he and his wife they're traveling all over the world, and they're going on trips, and it's maybe not how they thought their retirement was going to be, but they're taking advantage of the time while he's still able to travel and able to do those things to do those things. They're getting involved with us. He does a lot of speaking for us. He's an advocate for us. He's gone to Washington, D.C. and talked about the disease to politicians on the Hill in D.C., which is, it's an unusual thing to hear somebody with the disease talk about what it's like living with the disease.
I bet.
And there's a pretty narrow window of time for them really to be able to do that.
To articulate.
And so when people are diagnosed and they take that opportunity, that is absolutely priceless information for people to hear, because hearing it from me or one of my colleagues is not the same. It's not the same. When you hear somebody talk about what it's like every day, getting up, knowing that that day is going to be a struggle, from getting out of bed and getting dressed, and all the decisions involved with getting dressed. You and I do that without a thought. It's not a hyper-analyzed process. And someone with Alzheimer's disease, it takes a long time. Those decisions become very, very challenging. So maximizing that time, modifying your environment, all of those things are things that can be done with that diagnosis.
Well, you're very persuasive. That does make a lot of sense then, to get the diagnosis, to do it right, and then make plans for your life. Still, Alice, we're taping this on the day after the Academy Awards, so everyone's talking about that movie. What was your sense of it when you saw it? Is it portraying Alzheimer's, early Alzheimer's, pretty accurately?
I think to the extent that someone that doesn't have the disease can portray the disease, she does a really amazing job of really capturing the essence of really losing a part of herself. There's an interaction in the film with one of her daughters, and she talks about she was a professor and seeing words but not being able to say the words, and just sort of losing that ability to connect with something that she knew so well. And the movie does go into a lot of detail about an assortment of challenges, not just the memory loss in terms of words and speaking and things like that, which for her as a professor obviously were significant, but some of the challenges of just functioning very simply from day to day. And she has one of the most rare types of Alzheimer's disease, which is that familial type of Alzheimer's disease. So there's a little bit of conversation in the film about the genetic testing, which is not something that you or I would necessarily do. But in her particular case, because of her age, she was tested and was a genetic carrier. And so then her family was tested, and I don't want to spoil anything for anybody that hasn't seen the movie, but that's talked about a little bit, because that type of Alzheimer's disease is incredibly rare. Less than 2% of the diagnosed cases are genetically based.
Well, that's interesting too. I haven't seen it yet, so I'm looking forward to seeing it. But I've heard a lot about it, of course. Thinking of genetics, so many people I know my age are saying, well, my mom has Alzheimer's, I'm so fearful. And what I've heard is that if you're from a family in which one parent has Alzheimer's, your chances of getting it are about 30%. Statistically. Am I right or wrong?
I think how I would say it is it certainly is going to increase your risk. If you have a first-degree relative, which would be a parent or a sibling, I don't know that I can quote a percentage of what your odds would be, but my bigger question would be, when were they diagnosed? And oftentimes families say, well, they never got a diagnosis, but we're pretty sure something was wrong. Well, then you don't really know what you're dealing with. And so that becomes a real significant question. And of course, the age. If the age was, well, they were in their 80s, well, that's when the majority of people are going to be diagnosed anyway. So is it age-related or is it something else? And it's arguably an interesting conversation, because families get very concerned about it, and particularly as we age, the concern becomes more significant, I think. I look at my parents. My parents are 76 and 81. And my mom jokes with me all the time, when she forgets something, she makes sure to tell me how she resolved it so that I don't get nervous and take her to the doctor. But as we age, we all are going to have a little bit of struggle from time to time with memory, and that's perfectly normal. It's when it becomes an issue of functioning. So just having the parent with the disease, I don't know that I would be real concerned. I would be aware.
What about if two parents?
I'd still ask the same question. When, was there a formal diagnosis? How old were they? What is their family history? And then maybe you want to take a little closer look. If you have a sibling that has the disease as well, obviously, again, it's going to increase the risk. But you still want to take a look at how old, when was the diagnosis, or was there a diagnosis, and then go forward from there. And obviously, if you're really concerned, go to your doctor and talk to your doctor about it.
And to do the full-blown diagnostic workup, do you go to a neurologist? Are there specialists who specialize in diagnosing Alzheimer's here in Minnesota, or?
Yeah, we're very fortunate. I mean, obviously we have the Mayo Clinic in Rochester. We have numerous centers for memory and aging that do specific testing around Alzheimer's disease. But at a minimum, you want to go to a neurologist or a neuropsychologist, somebody that specializes obviously in those types of disorders. Going to a primary care doctor, you may or may not have good luck with a diagnosis there. It really depends on that primary care doctor's area of interest, how much knowledge they have in the disease, how much willingness they have. But ultimately, they should probably refer you to a neurologist or a neuropsychologist for those tests.
When you mentioned the forgetting, I thought it would be interesting to just have you give a couple examples, because people are on edge, I think, about, oh, I'm forgetting, oh my gosh, what if I'm getting Alzheimer's or another form of dementia? But give us some examples, Debbie, of what's normal forgetting versus what's dementia-type forgetting.
So a couple of examples. A classic one that we talk about is keys. When you misplace your car keys, and I'm sure you've probably done it, I've certainly done it, people that are watching have done it. It's not so much that you misplace your keys. It's, number one, can you retrace your steps to find them? So can you think backwards? Where did you have them last? A lot of times if there's a disruption in the routine, I just did this last week, so I'll admit it to you, I left my keys in the door. I had a bunch of stuff in my hand. I was trying to get through the door. The keys stayed in the door. I went in the house. And of course, when I went to look for the keys the next morning, couldn't find the keys. Went out into the garage. There were the keys in the door. How amazing was that? But obviously, I knew what the keys were for. I knew where the car was, all of those kinds of things. Where it gets concerning is same scenario. Person finds the keys, but they're not sure what they're for. Maybe they don't even remember that they drive anymore.
Or they put them in the freezer, something like that, right?
Or the refrigerator or a cabinet, and they don't know why they did that. And sometimes there's logical reasons. If you get distracted, sometimes you can do really odd things with items. Same thing like with a wallet or a purse, if you leave those things in the wrong place. Where we get concerned then is again, it's that being able to retrace your steps, to go backwards. People that get lost driving is another example. We've probably all gotten lost or gotten confused when driving. It's when you can't negotiate where you are, you can't stop and figure out where I have to go next, what direction am I going, do you have a GPS or some other type of device that can help you? All you know, sometimes we read about stories where a person leaves their home and they're gonna go to the grocery store and they end up in South Dakota. Or worse, they might end up even more tragically. And oftentimes, if people are not located, if they do wander like that, it's a tragic ending a lot of times.
I remember a speaker from your organization once said she first realized something was terribly wrong with her husband when he forgot how to get from downtown Minneapolis to their home in South Minneapolis, and he had done it, for 40 years. That kind of forgetting is a bad sign.
Yeah, and that's significant. That's losing an entire an entire piece of time, where something was so incredibly routine, and now you don't know how to do it anymore.
We are almost out of time. I don't want to not put your website up, and would you just give us your website? And via this website, you can get great support group information. But what are the
So it's alz.org, so alz.org/MNND.
So easy to remember. We'll put that up on the screen too. But via the website, the support groups, I think, are one of the easy things to track via, but they're wonderful, aren't they? I mean, and you've got support groups in every suburb of the Twin Cities, don't you?
I think we have over 150 support groups between Minnesota and North Dakota that are facilitated by over 200 volunteers. And I may be a little off on the numbers, they fluctuate a little bit. But support groups are pretty amazing things, although they're not for everybody. But they're really amazing things, and we have them for different types of dementia. We have them for adult children, people living with the disease, as well as caregivers. I do want to mention another thing that's really helpful is our 1-800 number.
Yes.
So for perhaps people that are less inclined, or maybe they just want to talk one-on-one, and that number is 1-800-272-3900. And I bring that up because it's a 24/7 phone number where you can call 24 hours a day, 7 days a week, and talk to a live person. You don't leave a message, they don't call you back tomorrow, somebody actually answers the phone. And a lot of times when people need support, they need it right now. It's not scheduled for 2 o'clock tomorrow afternoon.
Right, or we'll call you back,
when we have an answer.
Right.
So
That's
it's that
a wonderful
immediate
thing.
support. So that's another really good resource for people that's available here.
That's great. Well, Debbie, thank you so much for coming down.
Oh, thank
She
you.
just drove in from Duluth, and so I especially appreciate it on this cold winter night. We're taping in February of 2015. Best of luck with your work and your continuing education and advocacy and push to get more research dollars. Take note of that, folks, because we certainly need it. Thank you very, very much.
Oh, thank you so much for having me.
You're welcome. Thank you for being with us. I'll be back again next week. Until then, have a good week.